So that was yesterday, and it couldn't get much closer to the World TB Day. And invest to end TB and save lives. Now, the world is good in big slogans. What counts is the action that follows to these slogans. And as an example that this has been around for quite some time, I give you as a little wake up after the break a riddle. What has anybody an idea what that could be? Anybody an idea what this could be? Okay, I disclose it. It's called in German the Blaue Heinrich, the Blue Henry, and it's actually a sputum collecting bottle for sputum hygiene. People were trained not to spit on the road or in the open, and I would wish that we sometimes nowadays had a bit of this discipline, that people were not spitting in the streets, but more importantly, and this is also for the nursing and clinical officers, when we don't want to go for TB diagnosis, what you usually do as a good nurse, you encourage people to take really a good cough sample. But mind you, this should not be done in an overcrowded ward. It's not just COVID that is transmitted indoors, it's also tuberculosis. In one cough attack, there can be millions of, so they're outside on a balcony on the corridor to produce their sample for TB diagnostic there. So that's very old, and it is still very pertinent. There is another one, and this, I hope it's recognizable. This is a set, as you can see, where you can draw blood, and you have 3 sampling bottles. Any idea what that could be good for with regards to tuberculosis? Which blood test, do you know any blood test that goes along with TB diagnosis? Okay, it's good that I can still offer you some new information. And I give you on top a little bit of a German lesson. This is the collecting vessels there. This is how they are called. It's for the interferon gamma release test, and that's a very elegant way to prove whether one's immune system has ever been exposed to tubercle bacteria. And it's continuing to play an important role in the diagnosis of TB, and more importantly in the part that we call latent tuberculosis infection. And I will come back in the course of the presentation on that. Continuing on the quiz, we are not doing the quiz as such now, but what I would like you to do as your exercise, scribble down for you, because it will be answered in the course of the presentation, what is my personal guess how many people fall ill with TB annually, and how many of those die per year, like as of 2021. Scribble it down, and then give you a guess how many would that be. Many die in Zambia because of TB. We are not shouting out the proper guess about the order of magnitude. TB is an infectious disease, and this is also something why I like the program, because what we label countries like Zambia is a situation of the so-called double burden of disease, whereby countries still suffer from people with infectious diseases, have a high disease burden in infectious diseases, And at the same time, with lifestyle changes and aging populations, good luck. As I said, he sometimes scares me getting old. I still like to get old, but my risk to die gets higher every day because I'm getting old. So we have this double burden situation in countries like Zambia and neighboring Malawi and others. And there are certain basic understandings that I would quickly go through with you that apply for more or less all the infectious diseases. And these principles need to be there. And they were so much activated now also with the outbreak of the COVID pandemic. In any of these infectious diseases that I want to control, I need to know what is, how does it clinically present? Yeah? Is it a rash? Is it a cough? Is it whatever, headache, or a combination of that? Am I able to identify a causative agent? In the case of TB, it's now actually the 140th birthday because we are proud to say Robert Koch identified the mycobacteria tuberculosis in 1882. Then, if that is the case, how can we diagnose the disease? Where does it occur? Are there reservoirs? Are there maybe animal reservoirs? Are there environmental reservoirs, like in cholera outbreaks, yeah? Or rats in Yersinia pestis, in others? Then we would like to know what is the relation between the time of infection to the time of an index patient. How long does this person pose a risk to the environment? You may have known, I mean, in Germany, people were put in quarantine with COVID for 14 days. This is, by the way, the basis of that 14 days is the translation from the Italian and Latin. Quarantine means 14 days. Because we didn't know the transmission and the risks, so it was set at 14, and the more it got known and better understood, the quarantine time, meaning the understanding how long is a patient able to transmit, how long is it? And we know now we can interfere with that. HIV patients who are treated and they are virally suppressed, we know they no longer pose a risk to their sexual partners. And in TB, it would equal people who are properly treated do not transmit the disease anymore. So it's of utmost importance. Transmission, ways of transmission. Yeah? Remember again, HIV. I don't touch the spoon or fork in the room where an HIV patient has been. These, we didn't know. People were afraid. Still in the hotel now with COVID, they still put it in plastic bags, the cutlery, but we could say there is no sense in doing that because we know now the risk is what I'm doing now to you, but I'm tested negatively and vaccinated. This would be the risk. Many people in a closed environment, less good ventilated than this one, and not wearing masks. Can we identify especially, particularly vulnerable populations? In COVID, that was the elderly, but you know, for tuberculosis, that is different. Are there any means to prevent the transmission? Then, next step, if we identify a patient, what can we do for the patient? COVID again, there was very little to offer apart from symptomatic relief and hopefully oxygen, but I think everybody of you knows how bad it could be when there is no oxygen cylinder. So that's the patients, and then again, and that is also true for TB, of course, and was true with COVID now again, how do we manage contact persons, and who is a contact person? If I was an infected one, would I still be the risk for the green ladies over there? Most likely not, because it wouldn't go far enough. But maybe for him, I would be a risk. So it's not that trivial to define who is a contact person. There are rules and regulations how we do that in TB. And then, of course, the immediate environment, whether to clean, to disinfect. Yeah, very important, for instance, in cholera, much more important than to clean the environment. I'm not against cleaning the environment, but specifically, for instance, for COVID and TB, it doesn't apply that much. And then, of course, you have this unspecified category. You always have certain aspects that you need to do some special considerations. Now, the next step is something like this. Again, a little bit of a riddle where I also ask people, what would this bars, what has this to do with my topic of today? And I have to say, maybe this is not necessary to scale, it's just an example. So what could this, in disease control, what would the largest, the highest first bar potentially represent? No idea, you can keep it private. So this is the general population. How many in Zambia? 18, 19 million, yeah? So that's basically for TB as for hypertension, almost anybody is at risk. There is no innate immunity to tuberculosis. Then the second, what could that be? If we are talking TB, it could be the number of identified of TB cases. But mind you, also there is a relation to the previous talk. Do you recall the term masked hypertension? People who have hypertension, but they don't know. And the same applies for TB. People may have TB, and therefore the Airtel SMS of the Ministry of Health was good. Yeah, you may have TB because you say, I'm not really doing well, I'm losing unintentionally some weight, I don't sleep well. There can be very salient, unspecific symptoms. So these would be the true number of TB cases in a population. And then naturally, the next one would then be cases following now the advice by the Ministry of Health, I better go for a health check. So they go to a health facility and to health services. And then the next, it's not necessarily done, and I'm not talking about Tanzania, I'm working at Zambia, I'm working also in TB control in Germany, and it is not necessarily said that people who come with suspicious symptoms are necessarily investigated for TB, and that is much more risky in Germany because there are lower numbers. Doctors are not so familiar with tuberculosis. So these are the cases where you search for TB. And then the next one is how many of those are actually diagnosed with TB? How many of those who have diagnosed actually start treatment? How many of those are completing the treatment and eventually this is the number of being cured? And again, we can have a similar cascade for hypertension. Prof. Michael is hammering on the fact that diagnosing hypertension is not enough. The ultimate aim is to control hypertension. And the ultimate aim in TB is not to have them having TB, but to make sure they are cured, and that's not with infectious diseases, with transmissible diseases. It's even the point that it is important for the whole of the society. If I treat an HIV patient and he or she is below the threshold of detection for viruses, this is good for the person and it is good for the society. If a TB patient is diagnosed and treated, this person cannot transmit TB anymore. And we sometimes tend to forget. So internationally, you can generate some indicators out of this cascade, and you can use this for antenatal care. How many pregnant women are there? How many attend antenatal care? How many have a full scheme? How many have facility-based deliveries? And how many have born healthy children and the mother is also okay? This is a very simple tool and very active. And if you find larger gaps that are not plausible, this is where, for me as a also public health physician, the work only starts. It's not good enough to look, oh, we have a cure rate of 50%. Oh, well, that's great. Now, we can achieve 90%. Where are the lost 40 ones? Or how many do we lose between coming to the health system and being diagnosed and put on treatment? Where and why do we lose people? You know that with the 1990 or 1995, 95 cascade, yeah, being tested for HIV, being linked to treatment, and being virally suppressed. This is a similar model. This is more sophisticated. And this is already quite some years that Rufino and Neto developed that. Just a very, very brief recap of what is TB. It's an infection by Mycobacteria tuberculosis. It's hard maybe for you to recognize, but here are in the Thiel-Nielsen stain the red dots that are acid-fast bacilli, and this is where we say, sometimes you wouldn't know it. I want a diagnosis for Mycobacteria tuberculosis, but why do I call it AFB? Yeah. So that's a mismatch in wording, but that's acid-fast bacilli. And as you can see, up to, as I said, with one cough, you can release 3 million bacteria in the air, and that's quite a big amount, sufficient to infect others who live in the same household. The good thing is, it's the sunlight, UV light, kills the mycobacteria. Since we don't have that much UV light in Germany, we have rooms in the wards where you have artificial UV light. Yeah, given these circumstances, transmission for TB mainly occurs indoors. And that's also important for your control measures. Yeah? Okay, I think I have mentioned this in my introduction already, thousands of years. But one additional fact in this case, a special consideration, TB is very much associated with poverty, poor housing conditions, and it's still, although it has been with mankind so long, it is associated with stigma and discrimination. As I said, 1882, so 140th birthday. This is a very simple graph, but a very telling one. If you explain this maybe to patients who you diagnose with TB. On the right-hand side is this, how this could end up. But this is me, for instance, coughing my TB bacilli in this room. So this is how the aerosols flow. What can you recognize on this picture? Who is affected? Just speak out. Everyone, but in this particular one, who is more at risk, the high person or the small person? Mind that and keep that in mind. Children are very susceptible. They are a risk group because it requires less bacteria for them to develop infections, but they get more than the adult because the droplets tend to fall to the floor because of gravity. The COVID ones are much lighter. They remain in the air. So they are more vulnerable and more at risk. But the other thing is, kids are poor transmitters of the disease. Because if you imagine to reverse that, which child would then cough up to an adult, yeah, and they don't have such a strong cough anyway. And as I said, with their cough, there are less bacteria in the air anyway. So they are more vulnerable because it requires less bacteria to infect them to develop infection. And this is on the programmatical point of view very important, because I don't know how much it is followed and implemented here in Zambia, but this is why you should treat with prophylactic, chemoprophylactic treatment children under 5 in a household where a parent or an adult, be it the aunt or the uncle or whoever, was affected. And this is generally in the guidelines, but sometimes there were limits in the implementation. And on the pathophysiology, you can also look at YouTube and find osmosis.org, and it's a wonderful platform. They have good teaching videos. How it usually goes is that you are exposed and you inhale that, and then you develop what is called a primary infection, which is also called a GON. It's an individual name of somebody who saw that, a GON nodule, and that is usually in the upper parts of the lower lung. And then this can proceed to become, well, it can be cleared at that point because you have a strong immune system, so after the exposure and the GON nodule, nothing happens. But then the next step would be what we call a primary complex or Ranke complex, doesn't matter. This is then frequently that calcification occurs in this nodule, and that is then more easily to identify in the chest X-ray. Only a fraction, good luck for mankind, only a fraction of people who are exposed and infected actually develop TB, but that is being shown on the next slide. So from the primary complex, then, or to a lymphatic vessel, then it can be distributed across the whole organism. So multiple organ manifestations in tuberculosis. Restricted maybe to the lung, and that's the most important one, or a spread via the lymph nodes. You know, all lymph node, lymphadenopathy sepsis with hematogenic spread of the TB duct out from this primary complex. The primary complex can, however, remain under the control of the immune system for long time. This is why in countries like Germany, we see most of the TB cases in the elderly, because what we call immune senescence. So the whole human being gets old, but also the immune system gets old and frail. It's no longer so much in control. Then this inactive controlled focus can be reactivated and cause active tuberculosis disease. And actually that's in most of the cases, at least in Europe, that is the case, less than the primary infection, which is in the central part of the picture, and the other one that you can see that is then called post-primary. As a student, I can tell you, I struggled with the terminology of TB, and it took me ages to really sort it out. Primary, post-primary, first infiltrate, and so forth, and then given names to that. So, but what I want and what public health are in drug development, you must, and in immunology of TB, you must understand different things, but a basic understanding on how it works is mandatory. So again, a little bit of German lesson in between, but the abbreviation is the same: latente Tuberkuloseinfektion, latent TB infection, which is the big reservoir for TB. The humans are their own reservoir for the disease. You are in contact, but good luck, not everyone who is in contact gets even a primary infection. But we don't know really the percentage of that. There is no marker for that. But what we know, if we can show somebody has acquired an infection, again, good luck, almost 90+% do not develop disease. And some of them never in their life develop disease. Is, for instance, much higher. And in the old people, it is much higher, and was the HIV, because I know countries like Zambia had well-functioning TB control programs, and they were really impacted very much by the advent of HIV, the combination of HIV and TB. So most of them don't get it, 10% get the disease, and we have a window of opportunity to intervene with chemoprophylaxis. And then of those people who get infected and get sick, approximately half get it relatively early, and the others get it only later in life. If they get diabetes, cancer, they need maybe immune modulating therapy for rheumatoid arthritis or these kind of things. So all these people who you see now are all gave their permission to their photographs being taken. It's important for me to bring this message across. So you can see, hopefully you can hardly, and that's always the same problem, but you could see this lady on your left side. She looks on the picture quite healthy, even though the X-ray that belongs to her looks very, very bad. And on the other side, this gentleman looks terribly sick. So it is what we call a chameleon, yeah. And one radiologist in Tanzania sometimes said, if the X-ray is something different. I mean, just as a hint, it's definitely not always the case. But she has extensive pleural effusion, but she managed because it was accumulating apparently slowly, and she was complaining about increasing shortness of breath. Well, we can well understand if you look at this X-ray picture. Then this is the bronchogenic spread. So as you can see in the pictogram, the mycobacteria, because from the primary complex, it got access to the bronchial system, so the bacteria could be spread all over the lung. If it gets access to the lymph vessels, you develop the spread in the lymphatic system, and then you end up having these, and that's a good diagnostic sign. You can get that unilateral lymph nodes, but they can also be in different places. But what we see in this boy is a very typical finding. But mind you, typical finding is not saying it's the only way how it can present. Here you see another case, and in this other lady, you can see something that we call lymph edema, because a swollen lymph node is a blockage for the lymphatic flow, and so she ends up with a very terrible symptom with this big lymph edema, and you have really to do good massage and try to get rid, and of course treat her. This sometimes also occurs, for instance, in breast cancer patients. And then this is a very important picture to me, because it refers again to the kids. The manifestation in the spine, Pott's disease, is something that frequently occurs in kids. And you know, this is a young boy. He has been infected. He may never, because of this finding, have infected somebody else, because the bacteria is not in his lung and he cannot cough. But he will be affected for his life, because you will not get this spine straight. So he is disabled through a preventable infection. And I want you really to remember this. He has a broken spine, and this caused the collapse of the some vertebra, and leading to this picture. Okay, there are other manifestations. I'm afraid this is not visible, therefore I maybe skip it. Because it might not be well enough for you to see. The idea is that you can, by ultrasound can also be a diagnostic tool for tuberculosis, because you would find intra-abdominal lymph nodes, or you would find abscesses, for instance, in the spleen. But I skip it because it's not good enough visible. Okay, so we have talked about the disease, we have talked about the manifestation and so forth. So what can we do in the next step, how to diagnose that? And of course, there is the medical history, whether you can find out whether this person has been exposed, yes or not, whether they have clinical signs. The clinical signs in TB are unfortunately non-specific, because you can have fever, weight loss. You can have it in viral diseases, you can have it in cancer, you can have it in quite a variety of different diseases. You can use imaging. The most important one still nowadays is X-ray of the chest, or if you are better off, you can also use CT, because the CT scan is more sensitive to identify smaller lesions. But you can also use, as I was trying to show, you can also use ultrasound for the diagnosis of pleural effusion of lymph nodes, etc. The next slide will show you a little bit more on what I name here the urine LAM test. It's a good tool, also applicable for children, because the diagnosis of TB is notoriously difficult in children. And there are other supportive tests, that is the tuberculosis skin test, or the IGRA that I showed you, the collection bottles, the specimen bottles for IGRA testing, where you cultivate human T cells with antigen from mycobacteria. And those T cells from the affected patient, if they are exposed to TB antigen, they get active and produce a protein that is called interferon gamma. Maybe that's enough for that now. So, and the newer test is something that has a very difficult name to pronounce, lipoarabinomannan. And that's part of the capsule of the bacteria, and it is excreted in the urine. So it would be a very easy way, and it has been used for the diagnosis in HIV patients, but it's coming up because the test has become more sensitive. It has come up also in the diagnosis of TB in children. So there we are with the diagnosis, and you can also, I mean, this might be available, you can also find that and more, this picture you can also find in the internet. Quickly, the principles, we are not going to go into the details and the nitty-gritties of treatment, but it's always combination treatment. That's a bitter lesson that we had to learn, that if you use one drug only, you create resistance. Minimum time of treatment is 6 months. And that's also not trivial, because usually those patients, once you start treating them, they feel better after 2 to 3 weeks. And then if you say, well, I'm okay, I don't know, these are nasty drugs, I'm not going to continue this anymore. And there is where clinicians, nurses, public health officers have to work, public health promoters have to work with adherence support, you know that. They are associated with some more or less dangerous side effects. One has to watch out for the toxicity to the liver. Michael could speak hours on that, because this is his second very specialized field. But we have to be on the watch out. Usually in countries like here, we don't do the liver function tests. So if we see jaundice in the patient, then it is really, really already urgent to do something. And there are some drugs, hepatotoxicity, there's also neurotoxicity, and we would wish that we had better drugs, and good luck, the recent years have really brought up some newer medicines. Issues of adherence and the directly observed therapy, it was really a winning strategy, but however now it's more not so longer that I really sit with the person and watch him or her swallowing it, but to have treatment supporters who follow up maybe in the community whether they have really taken their drugs. So it's, in the strict sense, maybe it's still done in correctional situations, in prisons, where you really look at patients that they swallow the medicine. Now, very briefly, the very old-fashioned drugs that I already learned in medical school, and there is little that is left that is still the same to the time when I was in medical school. In many fields, you think you have to study again. But the old-fashioned drugs, isoniazid, rifampicin, pyrazinamide, ethambutol, and more or less common use streptomycin, are still capable to cure up to 90% of the cases, even though rifampicin-resistant TB strains and multi-drug resistant TB strains are upcoming. But I've seen Zambia, among other countries, is still very much in control of the multi-drug resistant drugs. And good luck, there are newer drugs. Something that has really reached very broad clinical practice are the fluoroquinolones, and more specifically the moxifloxacin. And then bedaquiline and delanamide and those in bold, linezolid, they are more available, and they are also, for instance, sometimes available for those patients with hepatotoxicity. As I look in my audience and estimate your age, I guess you will be witnessing revolutions in TB treatment, because on the molecular level, there is so much more understanding, similar to what has happened in HIV, that we could address the TB infection and the inflammatory process that is caused by TB at much earlier stages than we do it now. So, but that's an outlook in the future. So, the epidemiology. Again, on a very positive note, the incidence, and in TB it's more incidence as compared to prevalence, which is important for non-communicable diseases. We are more interested in HIV nowadays. How many new infections do we get and can we prevent? And the same applies for TB. So you usually report in your national reports X over 100,000 population. And this is where you have to get in with your estimates. Yeah? How many people per 100,000 get infected with TB in a year in a given country. Overall global incidence has greatly decreased, and that happened in the richer world with good hygienic circumstances and good housings. That occurred even before the advent of antibiotic treatment for tuberculosis, anti-tuberculosis treatment. But the little upward dips that you see, they were caused by the World War in Europe that created big problems. And to link with the current political situation, I can tell you that I do expect an increase in TB because of the war in Ukraine, because Ukraine is one of the countries in Europe with the highest TB rate, as is Russia. And in countries in war, you can imagine that nobody follows up whether you take your treatment. And both countries already have high rates of multi-drug resistant tuberculosis. So there is also a concern in Poland. There is also a concern next, of course, to this humanitarian crisis and the sympathy that you feel with the war refugees, that there can be an increase in multi-drug resistant tuberculosis. We have seen this before. That was the collapse of the Soviet Union, the collapse of the health system that led to that situation. So I don't preempt what the situation is like in Zambia, but far much better than in Ukraine, where 30% of the newly diagnosed TB cases are multi-drug resistant TB cases. And you wouldn't like to have this disease because treatment goes up to 24 months. And it is not a pleasant treatment to take. So, but the world has decided we want to get rid of TB altogether, and they have agreed on very bold indicators. So a reduction to baseline by 75%. If 2015 was the baseline, in 2025 there should be a global decrease in new incident. In the reduction of mortality by 75%. And if you look at the SDGs, the Sustainable Development Goals, it's even higher. And by 2035, they would say TB no longer is a public health concern or the cause of death. And another, also what I like, there is also an indicator looking at the social determinants of health, that no one who is affected by tuberculosis should have catastrophic expenses for the household, because if the breadwinner of a household is concerned, be it by untreated HIV or TB, they are not going to work, and it creates more poverty. So the WHO TB control program produces since 1997, they produce an annual global TB report. And in 2020, globally, now you can check with your estimates, 10 million got newly infected with HIV, and the males are on the higher side, other than, for instance, with HIV in countries like Zambia, where more females are infected. 12% are children, and in epidemiologic and in public health, they were really a kind of neglected minority, because children do not contribute to the transmission or to a negligible amount, so, and they can up in a very dire situation. Up to 1.2 or higher million deaths annually, still in 2020. And among them, and on top of that, 208 patients, 2,108 patients who were also known to be HIV infected. That was still a slow decrease compared to last year, to the previous, that is 2019. Or 2018, because it's always a bit delayed. You cannot report today the figures from 2022, but rather the previous date. Now, if then we all know early in 2020 we were hit by COVID, and that we now come to realize has enormous effect on TB. You see the number of new cases has decreased, but I will show you in a minute that this, well, we could say, oh, wonderful, good job, but the problem was that case notifications disproportionately went down. The masked hypertension, the masked TB was on the increase. There may be more cases being not identified. So otherwise, it remained quite the same. We have a smaller denominator, but still the estimate goes up to 1.3 million deaths. So the death rate has increased for the first time since we are looking, then this is an effect of the shutdowns of COVID, which we did not know any better means, but we must the expanded program of immunization, be it on antenatal and postnatal care, other problems. And to find the right balance. I forgot to tell you, this wonderful report is now this year for the first time. You can go to your app store, well, be it Google or being the Apple App Store, and you find an app, Global TB Report. And I think this is a wonderful new development. It's the first time this year that you can, free of charge, download this app and then go and find out different figures. Makes the job for me much easier, because I will never give the data anymore and say, you can look it up yourself. It's very easy. Okay, so an increase in the death rate compared to the previous year, and that's for the first time. Now, I promised, check your data again. I don't know how close you came. Last report from Zambia, 59,000 new cases, and roughly 10% of those diagnosed with TB died. And you have reported short of 500 MDR cases. So must be on a watch out to do that. If you are, and the problem is always, how often are we able to diagnose that? The new facility, the Gene Expert, I'm sure you, for HIV, you have heard Gene Expert, whether the bacteria is resistant to two cornerstone drugs, which are rifampicin and isoniazid. We know certain genes in the bacteria are determinants for drug resistance. And this Gene Expert allows that. Otherwise, the culturing of the mycobacteria is a lengthy process, and it is not so easy. They are able to do that and perform culturing in almost all the cases, close to 95%. I don't know, and then there is the baddest option is the extended drug-resistant tuberculosis, where almost nothing works anymore. This includes the newer drugs like the fluoroquinolones, and this is now maybe 10 10, 15 years ago that there was the first clear outbreak in a hospital in South Africa, that we knew about it, but it's then appeared in different countries. For instance, also in Israel, which was quite astonishing because Israel has a good health system, but they have a lot of Jewish immigrants coming, for instance, from Ukraine and Russia. So I mentioned it already time and again, there is an important impact on COVID on TB control. And one aspect that I liked was that Lucia Ditiu, the executive director of the TB partnership program of WHO, said, ooh, very early in the outbreak of the pandemic, she says, ooh, we look in amazement on a disease that is 120 days old, and we have 100 vaccine candidates in the pipeline, whereas TB we have lived with for millennia and we still have BCG. It's not a good comparison. So it was the vaccine, and I think I'm a bit optimistic that more modern vaccines, even on the same technology like we have this now for the COVID, might be coming up. Now here is the illustration of what I was saying, the sharp decline in case notifications occurring between January and June 2020. And there was no miracle that all of a sudden there were less TB cases. There was nothing to expect, but this coincides with lockdowns in many countries. And you can see this in various settings, and here more specifically even in countries that are among the highest burden of TB globally: India, Indonesia, Philippines, and South Africa. You can see in the report here for Zambia, you had a little dip. This is an unhealthy dip, not taking a nap. Well, the health system took a nap, so we detected less tuberculosis cases. But congratulations, Zambia. It seemed to have a program in Zambia. They would know how important this effect was in the African region. Over the whole WHO African region, this decline can by no means be explained by anything but the close down of the health facilities and the distraction because of the pandemic. And you see that it is in other countries, regions even worse. Now, why do we bother? And then come in our clever mathematical colleagues who then do modeling studies. And in the modeling studies, you can, with all the knowledge on TB treatment success rates, incidence rates, you can roughly calculate if we lose in our gap. And we know the theoretical out of modeling, putting in many factors, they can estimate, depending on the length of service interruption and the estimated recovery time, this can be quite significant. If it reaches out to up to 6 months until the normal level of TB program management has been recovered, then it will end up with a really considerable increase in death. And here it is exemplified for 3 countries, as you can see. For each month of lockdown, they estimate that there are excess TB cases, more than 200,000 during complete lockdown, and then 150,000 during. That is the worrying impact that this is for the first time since we are really active in TB control, including that it was one of the target diseases in the Global Fund, that we will estimate that there is more than 100,000 additional deaths, yeah, for every month of lockdown plus another. So roughly, we could expect that the death rate will climb up from 1.3 million to 1.5 million instead of going down to our target, yeah, that is 75% less than in 2015. So that's something. Are we active enough in our case finding and the case notifications were, and just a few words, Germany is very whole, and the strategies, I always say, if you clean this room, it's easy to mop the big dirt with a broom, etc. But if somebody said, we want to get rid of the little last remaining piece of dust, then it's much more complicated. Don't get me wrong, I'm not comparing TB patients with dust, but I just want higher than if you say, I want to reduce from a prevalence of or incidence of 150 per 100,000 to 70 per 100,000. That is much easier to achieve. They blame it on them. But these are people who have been lived and worked for 50 years, minority and an important part of our economy and wealth. And the debate was very fierce when the Syrian refugees arrived. We had active case finding and we identified more cases, and then the right-wing nationalist people blamed, you see, we told you these refugees, they bring us all the deadly diseases. No, we looked for them and it was good for them to get on treatment, and it was good for Germany to identify them early and get them on treatment. I think, as much as I like it, I would rather leave some time for questions and skip the topic of LTBI, only to say that here in Zambia, my recommendation would really be to investigate good whether there are children in the household, in particular children between under the age of 5, because their immune system is not yet ready to fight latent tuberculosis and to prevent them from getting active disease. So otherwise I leave this. So are we going to reach the control targets? Look at the current trend, minus 1.5% per year. This is up to the time before COVID. Now there could be a reversal. If we used everything in an optimal way, we could reach at the blue line, but we are far from that. And if we have even better drugs, shorter treatment, better case finding, etc., we could make it. But if you look at the current global trend, I have my doubts whether the global targets will be reached, but that should not discourage individual countries to do the best that they can to reach it. This slide is referring to something that treating and curing a patient is not the only one. Yes, 5 minutes is fine for me, thank you very much. Also be in an adult who starts late in treatment and ends up with a distracted lung. So there is a disease burden even once you are microbiologically, and that's another motivator, not just to say to look at incidences, but also at the outcome and to prevent severe sequelae of a tuberculosis infection. So as you see here, we are far away from the targets. Instead of getting a 20% reduction, in the first, with the incidence, we achieved 11, and now it's even getting more complicated. The number of deaths was targeted to be reduced by 35%. We have reached optimistically 10%, and the catastrophic household expenditure, we are doing better, but it's far from zero. We have reached a 50% reduction. So I think the other report by WHO is very true. There is a mismatch between the global TB commitments and the TB realities. And we also need to advocate that the spending, global fund, but also to mobilize domestic means and to recover from the impact that COVID caused. To sum up, TB remains one of the most deadliest infectious diseases globally. We have good tools. There is room for improvement, but we have tools for diagnosis and treatment that are available and functioning to reach the targets, and that means to eliminate TB as a public health problem. As I've shown, targets are not met, and COVID has reversed even some gains back to levels of like 2012. The war against Ukraine may well pose another risk for TB control efforts in states of Brazil where there was no such program. And Chreso should keep up in the health centers where you go, do good primary health care, you help to identify TB cases and get them on treatment. If you are more interested, the one thing, the tuberculosis seminar in the Lancet, it's open access, is a wonderful summary on pathophysiology to epidemiology and treatment. And the second title here is the study that I just narrated from Brazil. It's the most recent one, but also you see OA, it's open access. And that's me, Zikomo Kwambiri, and Mind TB can be cured and prevented.
War, obviously.
Not German war.
Ukraine-Russian war. I was about to say where you're coming from. So I'm thinking, as a country, as government, is going to diseases. So we had two presentations today. The first one was on internal medicine, which was very lively. The second one is this one on tuberculosis, extremely lively as well. So from ZMA and a representative from the students. So just two questions. No, it is no, actually it's not. No, I know in this group it's not being tired. You know.
Yeah.
You wrote something.
You have a question.
You have. So I said something. I'd better be a scientist. I said after people eat, things just move a little bit slower than expected. So now we have three questions.
Okay.
59,000 cases.
Yes. And you knew it before?
No, I just remember because I saw the slide.
Yeah. No, but did you scribble down something? And,
yes,
and what was your estimate?
I've packed it. So
huh?
I don't remember what I wrote, but I did write something. I've packed the book.
I did? Okay.
I think it's good that you remember the 59,000. Yeah. I also remembered that one. There was another.
There was a question here.
Where?
Thank you very much for the presentation. I just wanted to ask, what exactly is the importance of using the gene expert test? And looking in like the African setup, the countries are still developing. And in the Western countries, the Europeans are more developed. So in Africa, how many countries are really accessing the gene expert test? Because I'm talking about this because I'm more interested because my thesis is based on this. Thank you.
Yeah, thank you for the question. It's a very important one. But I have to say that good luck, and that is also a result of the Global Fund, that WHO was able to per level and in larger hospitals, but it has come down to several, I mean, even our partners in Lilongwe, the HIV clinic has one, so it is much more widespread. And the charm and the elegant thing is that it's extremely speed up the diagnosis. One problem in diagnosis was you bring the sputum and then you send the patient home, and to come back, we once assessed whereby this patient was could still infect, as our PCR test do it in other media available. It has been, the rest is done by the machine going further, so that you can easily recognize this is a cluster of infection. We got very different.
Now I'd like to call upon Ms. Mwape. Can I?
The GMX fund is actually available for the support for TB and also under the HIV/AIDS level. I mean, the turnaround time for TB Bacilli, diagnosis now is quicker. Yeah. Of course, the gold standard, the microscope is also available. So there is adequate, I need to underline that TB is curable. So please, notification, early notification. In any case, under the laws of Zambia, TB is a notifiable disease. So it's very important that we take that message. Notification of any suspected TB case and early commencement of treatment. The drugs are available as well. Thank you.
Thank you so much. I must say you caught me unaware. Good afternoon, everyone. As introduced, I'm Mwape from Zambia Medical Association. Firstly, I think the presentations were brilliant. My president of the association, in his absence, Dr. Crispin Moyo. Basically, the Zambia Medical Association is the official representatives of medical doctors and dental surgeons. So ours is an advisory role. We do have a key mandate in terms of influencing public health policies that are put across by the government, as well as influencing anything to do with public health. We have been collaborating with various entities, especially universities that have an angle of medicine as well, and I must say it's been very encouraging. So being here at Chreso, we actually look forward to many more ways you could invite us to participate, and just how best we can do better for you as well as our country. I think I won't say, but would really like to say thank you, and I will pass on the message to our president. Thank you.
Thank you very much. May we have some reaction, feedback from any student? Please just walk through. Oh yeah, as it is coming, so I would just like to emphasize that TB is curable, early notification of cases. I'm sure you do understand what that means.
Thank you very much, Madam Moderator, and thank you to all dignified stakeholders present and the students. Gift Namenda, the Student Union Vice Representative. The presentations were amazing, but however, I want to stress out one thing to the rest of us students. And as much as we get the information, it's up to us. We are the primary preventers of any communicable disease that we face as a country and globally. So when we get information such as on the pulmonary hypertension and disease, please let's engage and talk to our families, our friends, people that do not have access to this information. So once we begin sharing information, it will be easy for every one of us to understand the importance of screening, the importance of testing, and even those that have our mothers that are able to give birth through traditional birth attendants, we understand the importance of vaccinations and the respect that is supposed to be given when it comes to vaccination schedules. So please, as we get educative information that we feel can be of positive impact to our communities, let's do by all means to share. It could be through media means or maybe through friends that can spread the message to the rest of the country. That's what I wanted to say. Thank you.
End of our program. I'd like to thank the Vice Chancellor for having been with us from the beginning of the program to now. Our two visitors, Professor and Doctor, the registrar who kept moving up and down. Today we had two presentations, one in the main hall and another one here. So thanks so much, sir, that you managed to hold those two events. Thank you so very much. The deans on my right panel, you have been awesome. The organizers, the Dean of Postgraduate has made this whole thing possible for us, this presentation. Thank you for running up and down for us. ZMA will not take anything for granted. We know that most of your members are watching us on our online platform, and may I take advantage of this chance to also thank Ndola Campus. We have a campus in Ndola. They are following the deliberations online.